because nowadays many students are on Facebook also. So
86 have joined, so the rest.
yeah, that means the remaining will be on Facebook.
Yeah.
So
But
just me,
it takes about.
let me just verify Facebook.
It takes
Okay,
about. Otherwise, let them listen to the recorded section.
the record will be always there.
Yeah, that's all. Just leave them alone. Half of them will be sleeping and enjoying.
We can't prevent it, man.
That's
That's
what. So
part of life, no?
let me just start
Okay,
off. And
okay, I am starting off.
Abby, the first case will be a little longish, and then we have one human, the others are all liver related.
Yes, ma'am.
Okay, Doctor Karthik, are you ready?
Yes, sir. Good evening, sir.
Right shoulder portion. You can.
Okay, we have a little.
Yeah. Okay, you can start reading, and we'll keep questioning.
Yes, ma'am. This is a 45-year-old male, a bank officer, consumes alcohol 350 ml of beer daily for more than 20 years. Last drink was 4 days prior to admission. Jaundice for 10 days. So he complains of jaundice for 10 days. Abdominal distension and edema of the legs for 5 days. No abdominal discomfort or pain or fever. History of pruritus, generalized at night, more in the extremities. No present or past history of GI bleed, decompensation, hepatic encephalopathy. Urine output is adequate and bowel movements are normal. There is no consumption of alternative medication. No comorbidities. He's not married and he's a vegetarian.
Right?
So, ma'am, this is a 45-year-old male who with 6.
1 minute. We'll just move on to the next slide. All these will be short almost. So then we'll question you. Okay. Abhi, you can just take over.
Yes, ma'am. Karthik, based on your initial history, what do you think are the possible diagnoses in this patient?
Sir, this is a patient with a case of alcohol use disorder who now has presented with jaundice and ascites and pedal edema. So it is jaundice followed by ascites and edema. So it would be a form of decompensation, sir. So it is I would think of alcohol use disorder leading to a chronic liver disease with suggestive with the history provided, it looks like likely suggestive of portal hypertension may or may not be there because of ascites. I would consider that decompensation in the form of ascites and edema, sir, and jaundice, sir.
I mean, why do you say decompensation as your first diagnosis?
Sir, because sir, the patient has a long-standing history of alcohol use disorder, so it could lead to alcohol-related liver disease in the form of cirrhosis, sir.
So the question is, can somebody who is having alcohol use disorder,
yes, sir,
present with jaundice and ascites in the absence of cirrhosis?
Yes, sir. Alcoholic hepatitis is also a possibility, sir.
Okay. So I think that should be your first possibility should be alcoholic
yes, sir. So alcoholic hepatitis can also present with ascites, sir.
Yes, exactly. So alcoholic hepatitis is a condition where you can actually have non-cirrhotic evidence of decompensation. I mean, evidence
yes,
of
sir.
hypertension.
Hypertension.
And what would be your other options? I mean, other diagnoses for this provisionally.
So provisionally, apart from this, an alcohol. So apart from this, decompensation in the form of ascites and with portal hypertension and alcoholic hepatitis. Apart from that, ACLF is a possibility, sir.
So now we are talking about diagnosis, right? So we're not talking about symptoms.
Okay. Only
right.
diagnosis. It could be
number one is alcoholic hepatitis. Number two, you said because of chronic use, patient has acutely decompensated, which could also be ACLF. We need more information to actually identify that. What else could it be? the reason for jaundice and ascites in an alcohol use disorder, is it only strictly alcoholic hepatitis and ACLF, nothing else?
Sir, in addition to this, it could be because of, apart from this, sir, it can be because of, they could have developed HCC, sir.
Can you go back to that slide in history? Can you take that
Back to the slide, please. We can't see the slide, BT.
So vascular causes also, I would like to.
Can you see now?
No, sir.
No,
The
sir.
slides are not visible.
No, the point here is, as Abhi was telling, that this could be one alcoholic hepatitis. They can present with jaundice and ascites.
Yes, sir.
And you said this could be ACLF.
Yes, sir. So viral hepatitis.
It could
Exactly.
be ACLF. And what could have triggered an ACLF in this patient? What is the commonest triggering factor of ACLF in an alcohol liver disease?
So alcohol itself can be a cause, sir.
Alcoholic hepatitis.
Alcoholic hepatitis, sir.
Hmm.
Apart from that, viral hepatitis, sir.
Or what else can cause? Once you have finished alcoholic hepatitis, you have finished ACLF. Dr. Abhi is asking, what are the other possibilities in this patient?
Sir, hepatitis A, E, and if he has hepatitis B, reactivation can present like this, sir.
Exactly. Good. So, do you see that the history of pruritus?
Yes, sir.
Is at night, more in the extremities. Like it's sort of cholestatic picture, right? You get that in alcoholic hepatitis.
So in alcoholic hepatitis, sir, it is present in a very small proportion of patients, and it portends a poorer prognosis if it is present, sir.
Yeah. So
very
basically,
few.
you have to think out of the box. So viral hepatitis is a good DD because there is a presence of pruritus. Hepatitis A can cause cholestatic jaundice.
Cholestatic jaundice, sir, in the cholestatic case.
And what else would you consider in this patient?
Can it be an outflow tract obstruction?
Yes, madam. Vascular cause, so Budd-Chiari syndrome can present like this, ma'am.
In alcohol, in patients consuming alcohol, what is the pathological change that causes outflow tract-like presentation?
Ma'am, the caudate lobe hypertrophy.
Now, what is the where do you get the maximum changes in alcoholic hepatitis? So you get the maximal pathological changes in alcohol-related hepatitis. Centrizonal. So centrizonal hyaline sclerosis can present just like this, but only thing pain will be a feature. That's the other thing that will happen. Now, other thing is, can it just be an end-stage liver disease? Can it just, you think it's an end-stage liver disease, cirrhosis, portal hypertension, decompensation, it's end-stage? How will you differentiate this from ACLF vis-a-vis alcoholic hepatitis? And use the word alcohol-associated hepatitis, okay?
Yes, ma'am. Alcohol-associated hepatitis. Ma'am, clinically, alcohol-associated hepatitis would be more likely because of the history of pruritus, ma'am. That is the point that goes in favor of that.
Alcohol hepatitis per se will be all hepatocellular. You never get a cholestatic jaundice.
I mean, cholestatic jaundice.
Then you consider bone disease and other things.
Yes, ma'am. Okay.
Or you have CVD obstruction, something like that, you know. So
yes,
otherwise, per se, it's all hepatocellular. You agree to that, Abhi?
Yes, ma'am.
Yeah.
I would not put alcoholic hepatitis as alcohol-associated hepatitis as number one because of the cholestasis that is there. I would definitely consider an obstructive cause of jaundice also because cholelithiasis with cholangitis can also decompensate a liver disease. So these possibilities you have to keep. You know, only then you can actually go on to your proper examination and then ruling out.
One question here. What's the difference between severe alcoholic hepatitis and alcohol, that is ACLF, alcohol-associated hepatitis on a chronic liver disease? What's the difference between this and severe alcoholic hepatitis? What's the classical presentation of severe alcoholic hepatitis vis-a-vis alcohol-associated ACLF? I mean,
Ma'am, alcohol-associated ACLF, ma'am, it will be jaundice, which would be complicated with ascites and or encephalopathy, ma'am, and there will be a short interval between that of less than.
Why should you get encephalopathy? Encephalopathy is not.
No, ma'am. It may or may not be there, ma'am, and it's associated with a higher 1 month mortality also, ma'am.
We are not
Alcoholic hepatitis?
We're not talking about mortality. I'm asking you clinically, when a patient encounter a patient, how will you distinguish alcoholic hepatitis versus ACLF due to alcohol?
Ma'am, alcoholic hepatitis, ma'am. So on history,
severe alcohol association.
Ma'am, on history, ma'am, there will be high intake of alcohol at least in the preceding 60 days, ma'am. And the patient would give history of jaundice with symptoms of vomiting, anorexia may or may not be there. On examination, ma'am, there will be an enlarged liver, ma'am, in alcoholic hepatitis.
Just 1 second. They'll all be very sick, okay? The severe alcoholic.
Yes, ma'am.
These are all those like withdrawal symptoms will be there, you know. They'll have fever, they'll be toxic, they'll have tremors, tremorlessness of their fingers, and then on examination you have florid spiders, large tender liver, tensitis. So that's a totally different entity. It's a totally severe alcoholic associated hepatitis is a totally different entity compared to an ACLF. You agree to that, APK and Dr. Abby?
Yes, ma'am.
I think
usually patients can present with ACLF as the index presentation in heavy drinkers with underlying cirrhosis. But in alcoholic hepatitis, exactly like what ma'am was saying, it is actually a more toxic kind of hepatitis. The patients usually will have a very tender hepatomegaly. They have ascites, they have bipedal edema, jaundice, all of this will be there. But not very easy to actually distinguish purely on clinical. I would also suggest a clinical examination in such cases to look at other signs of chronic liver failure.
Any other questions in clinical?
I mean, now you have a lot of these DDs. Now let's move on to the examination.
Okay, sir.
Are the slides on?
Yes, sir. It's visible, sir. So may I continue?
Yeah.
On examination, the patient is conscious and oriented. Height is 154, weight is 72 kgs. Dry BMI based on ascites and edema legs.
How do you calculate that?
Ma'am, for ascites, ma'am, mild, moderate and severe, ma'am, 5, 10 and 15% from the body weight has to be subtracted and 5% in addition to that for edema of the legs, ma'am.
Okay.
Pallor is present, bilateral pedal edema is present, icterus is present. There is no lymphadenopathy. The saturation is 98% at room temperature. There is no asterexis. The patient is malnourished and presence of sarcopenia is noted. Vitals, pulse is 82 per minute, regular. Blood pressure is 110 by 70 millimeters of mercury, and the respiratory rate is 22 per minute, thoraco-abdominal.
Describe the findings that's there by the side.
Sorry, madam?
Describe the findings. You can see some figures, no?
Oh yes, ma'am. Ma'am, there is...
what it is and what's the mechanism?
Ma'am, palmar erythema is present, which is a sign of alcohol use. Ma'am, and Dupuytren's contracture also is present, ma'am.
Describe the features. I don't know what it is.
Ma'am, it causes the contraction of the.
I would like you to take up all these clinical questions, you know, because that's what they ask in the exam.
Ma'am, Dupuytren's contracture is the contraction of the palmar arch, ma'am, which leads to the flexion of the fingers, ma'am. And palmar erythema is the presence of the reddish appearance of the palms, which can be noted in this patient, ma'am.
What are the components of Dupuytren's contraction? What are the components?
Madam, there will be flexion at the proximal and distal interphalangeal joints, ma'am. And the fingers cannot be straightened despite an attempt to do, despite an extension attempts, ma'am.
All the fingers?
No, except the thumb, madam.
Is it? Or is it just the lateral two? This patient has had all, but then what is the classical presentation of? All this you should know, very important. They will ask you mechanism, they'll ask you what are the changes, which are the muscles that are involved. The patient also has clubbing. Okay, these are things. Now, there's a comment here, patient is malnourished and sarcopenia. How will you assess this?
Madam, so on examination, ma'am, there will be the prominence of the cheekbones, hollowness of the temporal fossa, and the mid-arm circumference can be measured, ma'am, which will be less than 17 will be suggested of severe malnourishment, ma'am. Sarcopenia, ma'am, is we test for the muscle strength, So a hand grip can be checked by using a dynamometer, ma'am.
Come on, continue. What are the frailty? How do you assess frailty and how do you assess sarcopenia? That's what you have to describe.
Yes, ma'am.
Mainly for this.
Ma'am, for frailty, in addition to this, ma'am, we'll make the patient do repeated standing up from the chair, and we'll tell him to walk, ma'am. There's a 6-minute walk test as well, ma'am, for these patients.
6-minute walk test. Please read all these in detail. What is 6-minute walk test?
Ma'am, the patient is made to walk between 2 points, ma'am, and
how many meters?
Sorry, ma'am.
What distance from here to airport is it?
No, ma'am.
Points, eh?
No, ma'am.
Ma'am, please ask all these questions, okay? They need to know all this, so just keep asking.
Yes, ma'am. Karthik, basically, what is malnutrition? What is sarcopenia and what is frailty? If you know this, you will know how to examine.
Sir, sarcopenia is the loss of muscle mass, sir. Skeletal muscle mass, sir.
Just upper limb, lower limb.
Sir, no, sir. Generalized.
Exactly. You should be very specific in your definitions, right? Generalized skeletal muscle mass loss is sarcopenia.
Yes, sir.
Right.
Yes, sarcopenia,
What is malnutrition?
Malnutrition is so malnutrition.
So there are 15 definitions for malnutrition. It's not easy to answer. So it's nutrition based and nutrition outcome based. So please go read this paper by Marinos Elias, 2017, where it's beautifully given the definitions and summary of malnutrition definition. And this is very important. You should know about this. Okay. It's nutrition and nutrition based outcome related definitions. You have to read this. Now tell me what frailty is.
So frailty is it refers to the decreased reserve of a patient, sir, because of which leads to increased susceptibility to diseases, and because of that, sir.
Reserve of what?
So that is not frailty.
Yeah.
So frailty, basically, you can actually clinically recognize it, but you cannot actually measure it. But you can assess it. Yes. Sarcopenia, you cannot clinically recognize it, but you can actually measure it. So that is a difference. So that is why when you say frailty, there is a frail scale. So you look at fatigue, you look at resistance, you look at ambulation, you look at illnesses, and then you look at the final one is loss of weight. So these 5 things form frailty. And your 6-minute walk actually assesses ambulation. Your climbing stairs is resistance, and your standing from sitting position is fatigue. So this is why we assess these patients regarding this. No, I mean, it's not just a blanket statement saying hand and all that. You should know why you're doing this. Right. So you need to know the 3 things, the differences, and how to assess it. Okay.
Next slide. So these are some of the things that you should know. What are the peripheral signs of alcohol-related liver disease? How to assess sarcopenia and malnourishment? And these already alluded to. And if there is any scoring system to assess the prognosis based on the scoring systems. Next slide. So I've kept some slides here. So frailty and sarcopenia, these are the things that I could download. So pre-sarcopenia assesses the muscle strength. Sarcopenia is plus the muscle mass. Severe sarcopenia is plus the performance. Okay, that is a function. Next slide. So you have tests for each of these. You have to read in detail. And in the exam, if it's a conventional, regular, live exam, then you have to do some of these tests. You must know what distance a person, how many times a patient is to climb up and down. Of course, the patient is too sick, he's bedridden, the performance scale is almost 3 or something, then of course you don't do any of the tests. So I've got the distance here. There's a frailty score that needs to be assessed, the muscle mass, at least remember the anthropometry. Muscle function here. 6-minute walk test, climbing stairs, standing from a sitting posture. Because this is what we advise them on discharge, so that they maintain the muscle mass and improve on the sarcopenia. Next slide. Next slide. So you have many of these. Previous slide. Previous slide, BT. Yeah, so there are these prognostic scoring systems for sarcopenia, male sarcopenia. So each of these has got some validity. No? Each of these scoring systems has some validity in terms of prognosticating the the disease of the patient. It's difficult to finish all this in half an hour, so the slides will be passed on to you. Okay, next slide. And then we have several of these kits. So you should know what are the kits: 6-minute walk test, what is liver freight index, what is Korsakoff's performance status. All these things you should know. This is a frailty toolkit. It's more like a calculator, so you can almost assess the frailty of the patient. Okay, next slide. See this, this is a scoring system. It tells you exactly what's happening to the patient. It's a calculator. You understand? So please go through in detail. This case is present. This case is being kept because any patient who consumes alcohol significantly will invariably have some of these features. Either they'll be sarcopenic or they'll be malnourished invariably. And death, most of them die because of this. Because they're predisposed to infection and they're not able to cope up with the problem that they have. Next slide. So these are all the diagnostic tools. I've written here 6-minute walking over. So here, this thing is there. The results of the tests. So these are the tests and what happens, how do you score the system, and based on this, these are the tools. Next slide. Just move on. So in this patient, cardiovascular system, respiratory system was normal. In the skin, he had psoriatic plaques over the dorsum of the hands. Okay, so just remember, there's also psoriasis. Next slide. Now just describe this.
Ma'am, there's mild abdominal distension is present, tortuous anterior abdominal veins, no back veins, liver and spleen are not palpable, shifting dullness is present.
Can you describe the veins, this patient? What are these veins?
Ma'am,
what else is glaring in this patient? Anything else in the chest?
Gynecomastia, ma'am.
Not much of gynecomastia. Anything else? Pectoral alopecia, no?
Yes,
no hair distribution. This
no
is
hair.
Classical, yeah. Pectoral alopecia is so classical in this patient. He had few spiders, but can you describe these veins?
Ma'am, they're dilated and tortuous, and they're supra.
Which vein is this? Name the vein.
This will be the, ma'am, not sure, superior epigastric.
Yes, superficial superior epigastric vein, which is linking up with the internal mammary. So this is a paraumbilical vein, which is communicating superior, which is a superior superficial epigastric, which is linking up with the internal mammary. You can almost see that going up the chest. So now what's the diagnosis? Anything? Next slide. I think there's one more slide. Shifting dullness is present. Just remember that.
That's one more slide.
Now, what are the things that you'll examine in this patient, the CNS?
Ma'am,
already highlighted here, but tell the significance. What are the higher functions that you would examine, and why is it important?
Ma'am, if the MMSE score, ma'am, mini-mental status examination, you look for consciousness.
When will you do MMS and when will you not do MMS?
Madam, MMSE, ma'am, in all patients who, ma'am, if they are well oriented, as was described in the general examination, ma'am, if he's oriented to time, place, and person, I would do an MMSE. If it is more than 24, then I would do an additional screening to look for minimal hepatic encephalopathy. If it's not there, as like in this case, it's 17 out of 30, then he would be in minimal HE will not be checked for, ma'am, in this patient then.
So what test?
And as part of
what test?
Sorry, ma'am.
MHE?
Yes, ma'am. Ma'am, we'll check for orientation to time, place, person. We'll ask the patient where he is, the time, date. Then we'll ask for recall.
Okay.
In addition to that, we'll ask for attention, ma'am. And sorry, for orientation, registration, attention, recall, and language, ma'am. So registration, we'll name 3 random objects.
So 1 minute, you know the components, no? But in a day-to-day practice, say when you're seeing the patient, can you do something with the patient to tell him that he's likely to have an MHE?
Yes, ma'am. We'll tell him, ma'am, we look for spatial orientation. So we'll tell him to draw a star or any object.
That fellow will not know how to draw a star. He does not even know what they're all illiterate. So
okay, ma'am, a square we can tell him, or
so just ask him to sign. So what will you see in the sign? Signature. There'll be micrographia.
Yes, ma'am. Small micrographia.
Micrographia is, it starts with big and then it comes down, you know. So we have that fall will be there. That fall will be seen. Now, in an illiterate person, do you have any tests that you read about?
Ma'am, we can do the
illiterate people.
Ma'am, we can tell him to join dots, ma'am.
Come on, yeah. This Dr. Demon, anything, read any papers by Dr. Demon? What is FCT1 and FCT2?
Ma'am, finger connection test, ma'am.
Not finger, figure. It's a figure connection, not finger connection. Figure connection. Figure connection. So it was done for all the illiterate people. So this figure, like it is animals and this thing. So it is more of a figure connection test 1. And so please read those papers of all the tests. If in the ward it is available, either the retain train test that is available, or you have a number connection test. What is most important when you're doing a number connection test?
Ma'am, the timing, ma'am, you have to.
You compare with. You compare yourself with him. You compare with the same literacy status. Remember that. Okay. If he studied up to standard 5, you take another person in the ward who's also studied up to standard 5 and then do the test. You cannot compare yourself with that fellow. So the time taken is the difference between the same literacy status. Okay. So sometimes in the ward, all these are available. So if hand grip dynamometer is available, ask for that. If the figure connection test is available, ask for that. So that it always adds marks, that means you are thinking about this and you're thinking the possibility of an MHE. Yes. Okay. So just one more. Yeah. So what's your final diagnosis? What's your final diagnosis?
Ma'am, this is a case of alcohol.
Final diagnosis. You've seen the veins, you've seen the ascites, he's got some peripheral signs. What's your final? And there's jaundice.
Ma'am, alcohol-related chronic liver disease, ma'am.
Come on, with chronic liver disease, what chronic hepatitis? Yeah, be more specific.
Cirrhosis, ma'am. Alcohol-related cirrhosis with portal hypertension, ma'am. In the form of, ma'am, ascites with decompensation.
Yeah, just give your diagnosis. What will you write in the case sheet in your diagnosis? That's what I'm asking. The final diagnosis.
Ma'am, alcohol-related cirrhosis with portal hypertension with decompensation in the form of jaundice and ascites, ma'am.
Sarcopenia.
With presence of sarcopenia and
psoriasis. There's a psoriasis.
And psoriasis, ma'am. And hepatic encephalopathy grade 1, ma'am.
And he's got that cholestatic jaundice. Okay, there's one hepatitis at 9. So just keep that in mind. Okay.
Yes, ma'am.
Therefore, the second add-on is maybe he's got an associated reactivation of hepatitis B, or there's a CAMP-induced, but something else is happening for the cholestatic.
Yes, ma'am. So to rule out virality also.
So all these things, please read. Okay, these questions are all kept for you to read. Next slide.
Dr. Cyriac wanted to tell something.
No, that was actually the previous slide, sir. I mean, madam was asking about checking encephalopathy in patients with minimal encephalopathy in patients who are illiterate. Please read about ANT test. Do you know what ANT test is?
So the animal naming.
Exactly. Animal naming test is a very good bedside tool to assess minimal encephalopathy. Just be aware of that also.
Okay.
Next slide. Okay, we'll go fast on this. So patient has got hypersplenism. INR is 2.03, non-diabetic, renal functions are reasonably okay. The entire lipid profile is low. Okay, that happens in patient chronic liver disease.
Yes.
There's hyponatremia, hypokalemia, grade 1 esophageal varices, echoes normal. All markers for B, C, and HIV were negative. Anti-HBS is not detectable, so apparently is not vaccinated, and well sodium was 28. Next slide. Next slide. So over a period of time, so 28 May to 21st June, there has been a significant reduction in the bilirubin, direct, everything, everything has started settling down. AG reversal continues to be there. So MEL sodium at admission is 31 and current it is 25. Next slide. We're just moving it fast. So, so it confirmed that the patient has got cirrhotic liver with normal blood flow. Okay. Next slide. Now, what are the things that you look for in a Doppler? And hepatic, when you do a Doppler, when you ask for a Doppler, what are the things that you're looking for in a patient with chronic liver cirrhosis with portal hypertension?
Yes, ma'am. So,
and define all these indices quickly in 2 minutes.
We look for the size of the portal vein, ma'am. we look for the flow in the portal vein, whether there is hepatopetal or hepatofugal flow, ma'am. And in addition to that, we look for collateral.
Normal flow is?
Ma'am, hepatopetal, ma'am.
Okay.
Define ma'am, what is congestive index?
When do you do Harry? When do you at least tell what is Harry? When do you do a hepatic artery resistance?
Ma'am,
that you should know. Post-transplant?
Ma'am, we check.
All these questions will be asked. When you do a Doppler, you're supposed to be knowing all these indices. At least minimum is you should know what is hepatic artery resistance index. You look for that, no? For the patency of the hepatic artery post-transplant. Have you any other questions here? I think all this
on Doppler basis, I think one more question is, what would you expect the hepatic vein waveform to be like in early versus an advanced cirrhosis? Hepatic vein.
So in early, no, so I'm not aware, sir. Sorry, sir.
So usually you have a triphasic waveform in hepatic vein. Yes. But you see in advanced liver disease like decompensated cirrhosis, you can actually have a monophasic waveform. So that is another additional thing.
That's because it will start becoming hepatoflugal, no? So automatically the phasic form disappears. In the early phases it will be normal. As more and more collaterals develop, there will be a siphoning of the blood from the liver. So you start getting that, okay? So patient had cirrhosis, plenty collaterals, massive splenomegaly, ascites, no SOL. Next slide. So please, we will not discuss too much about this, but just for discussion's sake, just tell what are the things 1, 2, 3, 4 under each category. That's all. Not more than that. Just diet. What will you recommend?
Ma'am, calories 35 kilocalorie per kg, ma'am. Will give the patient a protein of 1.5 gram per kg, and we would recommend salt restriction in addition to this of 4.6 to 6.9 grams per day, ma'am. And exercise, ma'am, will tell the patient that he would need strength training exercise, resistance exercises, and in addition to this, aerobic also. Yeah, and apart from that, sorry, ma'am, the diet, I would also give a midnight snack to these patients. Sorry to. So supplementation will also include calcium and vitamin D. Zinc role is controversial. Pharmacotherapy, ma'am, first for the alcoholic, ma'am, I'm sorry for the, sorry, ma'am?
Just list out the drugs, that's all.
Okay, ma'am, diuretics, ma'am, spironolactone first, followed by a combination with furosemide if it does not respond, ma'am. And apart from this, the medication would include basically supplementation for.
I don't remember. Varices was present or not? I don't remember.
Yes, ma'am. There was small grade 1 small varices.
Grade 1 varices, would you recommend provisional or any of these drugs? And if yes, why? If not, why?
Ma'am, for primary prophylaxis, ma'am, we would recommend it, ma'am.
Yeah, I think today even for small varices, they do recommend clinically significant portal hypertension. Agree to that, Abby?
Yes, ma'am. The current Babino 6 also recommends that you have to treat clinically significant portal hypertension. It reduces mortality also, apart from portal hypertensive events.
So please read about all the vaccines that you should give.
Yes, ma'am. Hepatitis A, B.
Yeah. Any other?
COVID vaccine as well, ma'am. No.
Any other?
Pneumococcal vaccine and
influenza.
Yearly influenza vaccine, ma'am.
Influenza vaccination. So that's important. And you think he should be listed for transplant?
Ma'am, the development of ascites, ma'am, with signs of portal hypertension.
Karthik, just tell yes, no.
Yes, ma'am. He should be.
Abby, you can just take 1 or 2 questions on liver transplant.
If you would like to put this patient on a transplant listing, yes, what is one particular criteria that you will look at? Just one.
So 6 months abstinence, sir.
Something better than that?
The abstinence is not a contraindication.
So you please read on the French-Belgium criteria for liver transplantation in alcohol-related hepatitis. The French-Belgium criteria. something that that is why we have good outcomes in European and American centers, because they select their patients very well. For us, it will be difficult because a lot of them actually relapse, and that is because they don't come into the French Belgium criteria. It's very strict, it is stringent, but it's one of the most important aspects. Just read about that.
Okay.
So can you can just give some take-home messages, Abhi, and just tell them so that
this patient, as we also thought about alcoholic hepatitis, isn't it? Alcoholic hepatitis. Bilirubin was around 22.3. He was actively drinking.
Yes, sir.
So is there any way you need to treat the alcoholic hepatitis?
So yes, sir. We would calculate the discriminant function score, sir. And if it is more,
basically look at for alcoholic hepatitis.
Sorry, sir. The various scores, sir.
One is
so Madry's discriminant function, the Glasgow alcoholic hepatitis score, the ABIC score.
The common thing will probably drive you to say that you might have to. Which are the two? One, you take discriminant function. And
yes,
what
sir.
is the MELD cutoff you like?
MELD sodium of more than 28, sir.
MELD?
More than 28. MELD more than 20, sir.
MELD more than 20. Then probably you will take up the Glasgow hepatitis.
Yes, sir. Of more than 9 and ABIC score more than 9, sir. And UK ALD score more than 56.
Would you like to do a biopsy on this patient?
Sir, no, sir.
Why?
Sir, because he gives history of significant alcohol consumption.
So the question is, would biopsy actually change your management?
Management, yeah.
Yes, sir. It would not change the management, sir.
Why not?
Sir, because sir, if the patient, if you have ruled out viral etiology with significant confidence, and the patient has presented acutely in this form.
Yeah.
Sir.
So, Karthik, your answer is right, because the alcoholic hepatitis histological severity scoring, the AHS scoring, has actually not been validated. Even though initially the scoring showed good prognostic validation, it was not externally validated. So there is no point in doing a liver biopsy unless and until it is part of a research program, not otherwise, not in a clinical practice.
The only other time you will find that you need to do a biopsy is that sometimes you should always remember that in alcoholic hepatitis itself, 50% of them will show a very heterogeneous findings in alcohol. And recently, if you see a lot of cholestasis and a Doppler reaction, then it may also suggest that these patients may not respond to steroids. So why waste time on steroids? That's also another thinking about it.
Yeah.
That's where you do a biopsy in this patients in your, when you are planning a pharmacotherapy on these patients.
How do you treat your psoriasis?
Ma'am, ma'am, for psoriasis, you'd give that retinoids, ma'am, and that psoralen-based therapy.
So you basically refer him to the dermatologist.
Dermatologist.
Make sure that he's not on any medication that can worsen the jaundice. No, that's important. Anything external. Any comments on that? This treatment, methotrexate and things like that. But be careful on that.
Yes.
So both of you can just, we can just give some, what are the things they should know? We've already highlighted most of it because this is the case that they get for the exam, alcohol-related disease. I think most
I think the basic questions that can come is, one is what is the importance of MELD versus MELD sodium? Because we were shown MELD sodium.
Yes,
what is the difference between MELD and MELD sodium when you treat a patient in the clinic?
So the addition of sodium to the MELD score, sir, so when sodium was not included, despite a normal MELD score, the patients were because of that, the patients don't get listed for transplant, and you need a cutoff of 15. So the MELD sodium, sir, with the addition of sodium to the calculation, it
So if you look at the UNOS criteria, still they don't use MELD sodium, they still use MELD.
Yes, sir.
The new MELD score, but sodium is not there. So it's not to actually include more patients, but something else. What is that?
It's a poorer prognosis with
In what sense?
hyponatremia. Sir, patients with hyponatremia have a high 6-month mortality, sir.
Why?
And
because they are prone to more of acute kidney injury and circulatory dysfunction, both of which are associated with sepsis. That is the only reason. It's not because it is superior to MELD, but it is superior to MELD because it can predict better clinical outcomes. That is why. But we still use the MELD criteria for listing. So this is one question they can ask you in acute and chronic liver failure or acute decompensation of cirrhosis.
Because sodium can be manipulated. That's why the UNOS still says that they should use only MELD on this. The idea, as Dr. Abi was telling, is once you're ascites and you have hyponatremia, then your survival comes down. You have high incidence of infection, and why do you get hyponatremia in patients? Because the liver has not been able to clear free water. That's exactly, and this is always portends a poor prognosis if you're not able to transplant these patients. That is why I think this MELD sodium was introduced.
Most of it. Yeah, Abhi, yeah, please.
Yeah, one last thing is you saw the sodium was 127.
Yeah.
yes, sir.
What would you ask the patient to do in this situation? What would you treat how would you treat this hyponatremia?
Sir, in fluid restriction, I wouldn't have for less than 125. It's recommended, sir.
What would you do? No, sir. Doctor is asking, what would you do?
So how would you treat this hyponatremia?
Sir, with so for 127, sir.
What have you been doing in the ward? Just tell that. That's it.
Yes. Sir, if there is first we would look for any signs of dehydration, sir, and any if there is any culprit medication, which like diuretic could be a culprit, in which case we'll withhold that.
Yeah.
And,
so Karthik, you never forget your MD training. If it is hyponatremia, see if it is euvolemic, hypovolemic, or hypervolemic. Okay.
Yes, sir.
And based on that, you treat. So if it is hypervolemic, euvolemic, or hypovolemic, you treat accordingly. So stop diuretics. If patient is severely hypovolemic, you give fluids and things like that. And you and always remember, you restrict fluid only if the sodium goes below 120.
120.
Will you use tolvaptan in this patient?
Sir, no,
Any
sir.
recommendation to use tolvaptan? Any
No,
benefits?
sir. It has been tried, sir. There are papers from Southeast Asia actually trying it, but
Okay,
it is,
good. There are no benefits. It increases sodium in the short term, but no clinical benefits.
no benefit.
Right answer.
Risk of brain.
We'll move on to the next case.
We can move on. Yes.
Yeah.
Thank you, madam. Thank you, sir.
Thank you, Karthik. We'll move to Dr. Kurivula. Dr. Kurivula, please.
Sir, yes, sir. Good evening, sir.
Please start.
Sir, a 20-year-old recently married lady, hypothyroid, pregnancy.
Speak loudly, be confident.
20-year-old recently married lady, hypothyroid, pregnancy 8 weeks, routine ultrasound shows massive splenomegaly with bicytopenia, non-bleeder, gravid viable fetus.
Next slide. Next slide.
One second.
Embryonic demise, misoprostol induced abortion later, need further evaluation.
So how will you evaluate? How will you evaluate this patient? Here's a lady who's 20-year-old, had a pregnancy, she aborted, and was induced by misoprostol. On examination, she had a massive splenomegaly, and she's referred to the hepatology department. How will you evaluate this patient? Fast.
Madam, since the patient is having splenomegaly, I would like to look
doctor,
at the
when a question is asked, just say, I will ask for 1, 2, 3, 4. Okay.
Madam, peripheral smear examination for initially I would look for to assess the anemia and the cause of splenomegaly and rule out any hematological causes of splenomegaly. Then
Doctor,
I would
what
like
test
to.
will you do? What investigations will you ask? She's come to you in the outpatient clinic with a massive splenomegaly. What investigations will you ask?
Madam, initially I would like to look at the peripheral smear.
You'll ask only for peripheral smear and send her off. Huh?
No, madam. Then ultrasound examination.
And you'll ask
Ultrasound,
for
peripheral
ultrasound.
smear.
So you'll ask for peripheral smear and ultrasound. That's it. Huh? Come on, one of you please take over because then I get irritated. Please take over.
Hemoglobin is 11 and total count is 2,900.
I think hemogram
Neutrophils
is not
is
important in this patient. Why are you hopping on peripheral smear? Is hemogram not important?
hemogram, madam. Hemogram.
Is it not important?
Anemia.
See, if you're slow, you lose time. Okay, please be fast.
WBC showing reduced total count.
Let's move on. WBC count is low, platelet count is low.
Platelet count is low.
MCHC is also platelet count is 0.7. What's your interpretation?
0.7.
What's your interpretation? The hemogram.
Pancytopenia. Pancytopenia. Bicytopenia.
Bicyto. What does it indicate?
Splenomegaly because of the splenomegaly.
Bicytopenia.
Splenomegaly. Because of the splenomegaly, patient is having bicytopenia, madam.
VT?
Yes, ma'am.
Yeah, ask questions.
Just a small spleen will it produce, or what actually happens in spleen? Dr. Abhi, please take over. Probably.
So, Kurula, you have a pregnant lady who's lost the fetus, and on evaluation was found to have a large spleen, right? Simple. And you have these bicytopenias. Now, the question was, how do you assess a woman who has had a pregnancy loss with bicytopenias? That was a simple question. So you have mentioned hemogram, you have mentioned a peripheral smear, you have mentioned ultrasound. So these are the findings. Now, what do you come across based on these findings that you see in this patient?
What is your provisional diagnosis? What's your diagnosis? See, doctor, if you don't speak.
Pregnant lady with.
So, Kurula, if you don't have a diagnosis, you can always say a syndromic diagnosis, right? You can always say a syndromic diagnosis. You can say massive splenomegaly with bicytopenia with pregnancy loss in a primigravida. You can say like that. I mean, your summary becomes your syndromic diagnosis, right? And you need to evaluate more.
So anyway, we just move on. It's not answering. So the renal functions were normal, electrolytes were normal. Just 1 minute back. The liver, the AST, ALT, marginal elevation of ALT, no reversal of AG. What are the
what do you expect in our country? A lady who comes with a massive with a splenomegaly, suddenly incidentally detected splenomegaly, and she's also become pregnant. What are the cases you would have seen in your this thing like this?
Non-cirrhotic
prototype
chronic myeloid leukemias,
who has become pregnant,
leukemias,
has got splenomegaly, has got hypersplenism,
myeloproliferative syndrome, sir.
Between myeloproliferative disorders or between an EHPVO, which one you would have seen in these patients? In India?
EHPVO, sir.
Yeah, mostly EHPVO or a non-cirrhotic prototype, or it could be a myeloproliferative syndrome. Okay. See, incidentally, she is detected, and the fact that she has become pregnant doesn't mean, generally means her liver should have been fairly all right, isn't it? Because if there is an element of chronic liver disease, the fertility rate definitely come down. So you will see a lot of EHPO people. Incidentally, we have seen EHO being picked up in a routine examination of the spleen in a pregnant woman. Okay.
Yes, sir.
Why is it important to do a prothrombotic workup in this patient?
Madam, she had an abortion.
What I would tell is, anyway, for the other people who are listening, this lady had an abortion, no? And actually, it's a precious baby or something. All the more you have to ensure that at least the next pregnancy she goes through. You need a complete JAK2 mutation first and then work up the entire prothrombotic profile so that she does not have a loss a second time. And the fact that she's lost the fetus indicates either there's a chronic liver disease cirrhosis underlying, so she's predisposed and she may never have a second pregnancy. The other thing is whether she has an underlying prothrombotic stage. So that was what was in her mind. So hepatitis B virus, there's low anti-HBs, rest is negative, HCV negative. Okay, move on. Next slide. So what is the 1 minute? What's any role for endoscopy in this patient?
Yes, sir. Yes, ma'am. Because of the to rule out any varices.
Why do you want? You said chronic myeloid leukemia. You said peripheral smear. Why do you want an endoscopy?
Madam, extrahepatic portal vein obstruction can present like this and can lead to fundal varices.
Only extrahepatic?
Non-cirrhotic portal fibrosis.
Only non-cirrhotic? Underlying cirrhosis, yeah, all portal hypertension. So you're suspecting, you have to rule out, no? And patient has got bicytopenia indicating that it can. So what are the non-invasive measures of predicting varices? All this you should know, the Apple score and all that. Now describe the varices. And tell us what is the latest classification of gastric varices. I want someone to back up Kurvila because he's slow. Who's the backup for Kurvila?
Vivek Joshi.
Vivek, classify these. What do you see and what are these? Classify the varices. Vivek?
Large esophageal varices. Good evening, ma'am. Large esophageal varices.
Can't hear you.
Hello.
Cannot hear you.
Am I audible now, ma'am?
You're very faint.
Okay, little more. You'll be closer to the computer. Okay. Fine.
There is large esophageal varix, grade 3 according to Piquet classification, and there are also fundal varices. Fundal is F2. That is tortuous.
Increase your volume, yeah. We cannot hear you.
GOV, yes, gastroesophageal varices type 2. Associated with esophageal varices, grade 3 esophageal varices, and GOV2, that is grading F2.
There are some changing classifications, no, for gastric varices in recent times.
Yes, ma'am.
So are you aware of that?
Yes, ma'am. So that is according to location. One is laser curve varices. Second is fundal varices, the cardiofundal varices, and third one is distal gastric varices.
You are saying Cyriac classification. What other classifications that do you know?
Sir, another is for grading F1, F2, and F3. F1 is just dilatation of fundal varix. F2 is tortuous varices, and F3 is tumorous.
So that is the oldest classification. What is the latest one? What you mentioned now is known as the Choi classification, where the Japanese Portal Hypertension Society has taken over. What is the latest classification of gastric varices?
We sent you the reference also. I sent you the reference. Dr. VT, LDK all have sent those.
Yeah, on 15th, the class on the 15th, I think I have sent the AGA, latest AGA practice guidelines, which came on 17th of June, I think, and cardiofundal varices, lesser curve varices, and distal gastric varices. Okay. And not only that, you have to find whether there's a communication between, whether there's an active communication between the left renal vein. That's most important.
Gastro-renal communication.
Yeah. So there is a hemodynamic classification of gastric varices. It's very important. Okay, you have to read about it. Kiosu classification, Hirota BRV classification, Saad Caldwell classification. These things you should know because you have to plan a lot of new treatments for these patients if they come with rebleeding.
Till now,
based on the treatment, I think now it is Caldwell-Samath's classification is what is being followed now.
I mean, there is something known as afferent classification and an efferent classification.
The efferent
based on presence or absence of large shunts.
So I think the change in the terminology from Sharin's classification to new AGA is nothing political or national. It is based on an approach to the treatment. Cyriac's classification basically looked at the location of the varices. Okay, now it is the approach to treatment, especially interventional radiology and other things. I think all of you read up because this is a latest one. Examination most probably will ask you this question. Okay, we'll move on.
How do you manage this patient? What should you do now with the varices?
As there are large esophageal varices associated with fundal varix, I will go for endoscopic varicose ligation, and for fundal.
We go for in a non-bleeder in fundal varices. Is there a role for prophylactic this thing? Abby?
So if you look at that, the patient has GOV2, right? That's a major aspect of it, and possibly there is a large shunt. So if you want to do a band ligation, what is your evidence based on? Where is it recommended that you have to do a band ligation in this patient without a bleed? Where is it based on? I mean, can you quote some study?
Actually, according to Baveno, we should start only a non-selective beta blocker.
Exactly. So your first option is a non-selective beta blocker. The only study where it has shown that cyanoacrylate blue is actually better than non-selective beta blocker is Professor Cyriac's study, 2011, Journal of Hepatology, but it is not blanketly recommended. There is only one study. So we always follow the non-selective beta blocker as a primary prophylaxis. Okay.
As it is, there is no endoscopic intervention as a primary prophylaxis in gastric varices. Is it true?
Yeah, primary prophylaxis, I think
intervention never endoscopic, it's only non-beta this thing.
Beta blockers, but there are some suggestions in some groups. Some surgeons are very aggressive. The patient coming from remote areas, very large varices, and all those things. Some people even recommend surgery, but not based on any recommendation. It's all anecdotal reports or individual opinions.
Only corollary is that gastric varices, they bleed at much lower portal pressures.
Yes, true.
Than esophageal varices.
Yes, so the patient had liver which showed surface nodularity, mild caudate lobe hypertrophy. There's recanalization of blood to vein, and there are some splenic infarct, mild ascites. What should you do with the patient now? And what are the next slide that will answer all these questions fast? Next slide. What are your differentials in this patient?
My differentials are first is
management of varices we have done. Now subsequently she plans for a pregnancy. What will you tell? What are the chances of conceiving? What are the chances of her having problems in pregnancy? Should she go for adoption?
Yes, and there are increased chances of having repeated abortion due to hypercoagulant state. So for this patient, I will...
She has no hypercoagulable state. They're all negative. What are the chances of her conceiving? So all this literature you should know, no? The chances of her conceiving and the chances of her having again preterm, again she's likely to abort. So chances of what? So you must know the percentage, the likelihood of her going to term, even to 32 weeks. And she has a huge spleen that's occupying almost the whole of the abdomen. Understand? So these are the things. And any role for splenectomy?
For this one, I will rather consider shunt surgery as compared to splenectomy.
Why shunt surgery? I mean, she has not bled. She has no hypersplenism. She has absolutely no clinical events related to portal hypertension. Why shunt surgery? So what is the new term for non-cirrhotic portal hypertension?
Non-cirrhotic idiopathic portal hypertension.
No. Portosinusoidal vascular disease, PSVD. Please read the Lancet Gastrohepatology paper, 2019. PSVD is a new term. EHPVO is out of it. Okay, it's a different thing. But care is also out of it. But PSVD is a new term. And in this patient, what would you suggest? She said that, I want to try for another pregnancy. Would you say yes or no?
No, sir.
Why?
Sir, such liver decomposition is not there. So,
can you raise your voice? We can't hear you at all.
So this patient has cirrhosis or non-cirrhotic portal hypertension?
Non-cirrhotic portal hypertension, sir.
So why do you say no to a second pregnancy or a second conception? Why? So NCPH patients can conceive. They have no problems with conception, but the problem is with prematurity or early abortions. So you have to actually plan an expertise treatment along with hepatologists and obstetrics and gynecologists, and you can actually take these pregnancies to term. At what cutoff do you think this pregnancy is going to be safe? At what week? That you can say that with some confidence, yes, now I think we can go on safely. At what week?
I'm not aware of exact weeks.
At 20 weeks. If the pregnancy goes beyond 20 weeks, high chances that she can actually conceive without any other events. Okay. Read about this paper. It's by Andrade et al., Journal of Hepatology. It's 2020.
We can just pass some of these references, okay, to these Thomas, and he'll send it to us in our group, okay? All these
I'll do that.
Yeah, all these 3 or 4 important references, please pass it on. So these are all practical issues, Vivek. So just see that. So these are this lady asked, can she conceive? And I discussed with Dr. LVK, the same patient. He said, right now she's safe. And if it can somehow carry on to 28 weeks, then we can push her through. So the problem is this, that within 8 weeks, she aborted this time. So the problem is that. That's why they considered APLA, but APLA was negative. So then now we have told her, if at all, just wait for 6 months since she's started DNC and all that. And then after 6 months, again, plan for pregnancy. And then as Dr. Abhi mentioned, under close opinion or consult with the hepatologist as well as the gastroenterologist hepatologist as well as the ops and gynae. Okay. So this was one of the recent cases that we saw. All right. So we just, since the time is short, we've just highlighted some of the important, these are the practical cases that you get in exam. Okay. Okay
then, Doctor, thank you, Dr. Vivek and Dr. Kurula. And now, Dr. Praveen, please.
Yes, sir. It's a real short case.
Okay.
You have to just, okay, this is a 52-year-old male, burning sensation epigastrium referred, passing black colored stools for 3 days. Next slide.
Burning sensation present in the epigastric region with belching, postprandial fullness and early satiety. History of loss of appetite is there for 1 month. History of passing black color stool present for 3 to 4 episodes, which is semi-solid in consistency.
BT, is this the, I wanted that spotter, no?
Okay. So yes. You want to?
Yeah, just switch over to the spotter case. Go to the next case. Go to the next case. Just move on. Move on to the next case.
Next case.
Next case, yeah. Go to the next case. It's a spotter again because I wanted all the liver cases. Yeah, that's the one. This is a 39-year-old male, known CKD, hypertension, and referred. Yeah. Now, when all a hypertensive patient will be referred to the hepatology department?
Hypertension.
Hypertension. If you answer like this in the exam. What hypertension? Now, just I'm asking a simple question. When the hypertensive patient be referred to a hepatology department? When all can you get hypertension?
In case of
Vivek, Karthik, all of you be just don't. You can't waste time. Quick, Vivek. What are the hypertensive situations when a case is referred to the hepatology department? Karthik.
Yes, ma'am. Ma'am, if the patient presents with metabolic syndrome, ma'am, fatty liver and associated diabetes and hypertension, so asymptomatic elevation in the liver enzyme.
Just keep telling number 1. Number 2.
So fatty, ma'am. Apart from that, ma'am, any history of hypertensive?
I'm asking you a very simple question. If you find a liver patient with hypertension, what are your differentials? Very simple.
Yes, ma'am. Sorry, ma'am. Ma'am, any non-alcoholic fatty liver disease, ma'am.
That you're repeating the same thing again.
Sorry.
Sorry. HBV, HCV, polyarthritis, polycystic liver disease. So whenever most of the patients who come to the hepatology liver clinic, most of them will have a BP of just 90 by 60, 100 by 60 rarely. But once you get 130 by 90, I think you should be immediately taken aback. Okay, there's something more in the systemic rather than in the, or it is one of these. Are you understanding what I'm trying to say?
Yes, ma'am.
Okay.
Yeah, so you can have a diabetic NAFLD, we said, then this is the other one, B, C, B virus, C virus, all affecting the kidneys. polyarthritis nodosa, and then you have the polycystic liver disease. Whenever there's a hypertension, just see that you have these in your differential. So basically, the platelet count, everything was normal. LFT is normal, sugar is normal, creatinine was 11.1, 1 was 57, sodium, potassium was 6.8. So basically, CKD, okay? And then HbA1c is also positive. So what's the next investigation you want? So these are the things you need to know. Liver diseases, non-cirrhotic associated renal failure, features of renal involvement. Dr. LBK keeps asking this question: how does HBV and HCV cause hypertension, or what are the various pathological changes in the kidney that take place in HBV and HCV infection? It's a very common question that is asked. Okay, just see that you know about all this. Okay. So what's the next investigation you'll ask for? And patient and HbA1c positive, E antigen negative, and HBV DNA is less than 10. So just keep this in mind. Okay.
Okay.
Now what's the finding?
Ultrasound showing multiple cyst seen in the liver, ma'am. Liver multiple hypoechoic in the third picture below. That
Is
is
liver, huh?
Is it
kidney,
liver
kidney,
or
That's the end of the story.
this is liver? This is liver. The
okay.
second one top is kidney. This is kidney. This is again liver, no? So this is the top one is first. Top left is the liver. This is the kidney.
Who's presenting? Kurvi does it.
No, ma'am. Praveen, ma'am.
Ravi, now please, for heaven's sake, don't make mistakes. You're not able to say which is liver and which is kidney.
Sorry.
Nothing to be sorry. You don't have to be sorry for me. That means you've not done it either. Most of the time, we used to do an ultrasound ourselves. Otherwise, at least go and see when an ultrasound is being done. How can you say the third figure is liver? Be very careful in the exam. Don't blame the examiners if they fail the candidate. It's our own fault, no? How can you ever say that the third figure is this? Now describe the CT finding.
Yes, ma'am.
What is this?
This is a CT plane which is showing multiple hypoechoic lesions in the right lobe of liver, as well as in the second image also showing multiple hypoechoic lesions. In the third image, there are multiple hypoechoic lesions in the both right and left kidney.
Don't show, don't point.
Okay.
Pointing, then they know what it is.
Okay.
Multiple hypoechoic lesions, multiple cysts seen in the both right and left side of the kidney, ma'am. In the third, fourth, and the fifth images.
Come on, tell what's your diagnosis?
Autosomal dominant polycystic kidney disease with associated liver cyst, madam.
What is that called? Dr. Abhi, LPK.
So Praveen, you have mentioned ADPKD.
Yes,
with do you think this is polycystic liver disease or something else? So what is the difference between ADPKD with multiple hepatic cyst, and what is the difference between ADPKD with the polycystic liver disease? How do you differentiate that?
He does not know.
Okay. Anyone knowing Karthik? Do you know the answer? Jagdish, do you know the answer? Can Jagdish take over?
No, sir.
Okay.
I think you have to read this. Even though it's a rare scenario, but this can come in your question also, in your theory as well as your practical. So this patient, if you have a polycystic liver disease with ADPKD, you will see innumerable cysts, minimum size 10 centimeters. But we don't see that here, right? So this is ADPKD with multiple hepatic cysts, which is different from ADPKD with ALD, which is polycystic liver disease. Okay, that's very important. And how do these patients present from a liver point of view? ADPKD patients presenting from a liver point of view, how do they present?
Incidental detected during imaging.
Asymptomatic. Okay, next, go on.
Sometimes that cystic and rupture can have an abdomen pain or.
No, I'm talking specifically about liver, not the general presentations.
Okay.
So can they have portal hypertension?
Yes, sir. Patient can develop portal hypertension.
So what are the reasons for portal hypertension in patients with ADPKD and PLD? What are the two instances where you can have portal hypertension? So one is because of the cyst replacement of the parenchyma and increased sinusoidal pressure. And second is something known as congenital hepatic fibrosis. So you can have these presentations in the form of large nodules also. They may not be actually cysts. So CHF can also present with ADPKD and cause portal hypertension. So I think this particular topic nobody has read, and I think you should all read about this. Different types of portal hypertensive features in patients, or liver disease features in patients with ADPKD.
Very important. And in this particular patient, when I examined, the kidneys were so huge. Actually, it was not palpable. It was the whole abdomen is occupied by the kidneys. So I tried doing ballotability, tried feeling nothing. Even just one nodule was felt in the right lumbar region. So that's the other thing. So suddenly you'll come up with a case, they'll say hypertension, and they'll just put the CT, and then on examination you may not pick up anything, and you may not pick up portal hypertension. But just remember that once there's hypertension, see that you examine the liver in detail, see that you examine the kidneys in detail. Don't miss on the kidneys in a patient with hypertension. Very, very important. If kidneys are not palpable, then you land up with hepatitis B, C, and other causes of CKD. This is a common scenario. And then the patient is also S antigen positive. Of course, the DNA load is low, so the vigor will shift towards the management of HBV and the management of this. So what should be the management? How will you manage this patient?
Management for HBsAg patient is carrier.
That's an easy way to answer. Now tell about the management of the polycystic.
For polycystic kidney disease, they based renal transplant or dialysis they have to do. For liver, actually, it is
doing dialysis. Yeah.
Yes,
so the case is referred to us. What should I tell them?
For the liver cyst of small size and all, we can observation follow up with ultrasound.
What's the difference between Carolese and what's the difference between Carolese and polycystic liver disease?
Caroli disease, it will be associated with multiple cysts in the liver along with.
What is the major difference? Polycystics are non-communicating. Whereas the Carolese are all communicating with the system.
Communicating with the biliary.
This is the biliary communication with the Carolese disease, which will determine the cystic dilatations. Whereas polycystic liver disease, you don't have communication.
Any other things that they should know at the LVK?
So I don't think they've mentioned medical treatment for this.
Yeah, there is no medical treatment. Actually, all medical treatment like octreotide, tolvaptan, and all those things are very experimental. That's all. There is no established medical treatment. Because sometimes examiners may ask, so the candidates must be bold enough to say that there is no medical treatment. Because for a polycystic kidney disease, I think tolvaptan is used because on action on some receptor or some mechanism. For polycystic, that has been advocate of the kidneys, but for liver, no medications.
No medications. Even though some use mTOR inhibitors and octreotide and somatostatin analogs, but it only reduces progression of cyst size, but does not affect the clinical outcome.
Okay, shall we move to LVK's case?
The last case, LVK's case. So what we have done today is actually we have not discussed quite often alcohol-related liver disease. We've just given you a glimpse of that. See that you read about pregnancy and non-cirrhotic portal fibrosis. I mean, these are all the common cases that you'll get. Bedside clinic, and causes of massive splenomegaly. How do you define massive splenomegaly? How will you differentiate it from a renal? I mean, questions are just basic clinical questions will be asked. And it will be actual in day-to-day practice. How do you, when you encounter the patient, what are the investigations? Now, you cannot start by peripheral smear, no? At least you need a CBC, initial CBC and a peripheral smear, and then you take off from there. I don't know why you went into this chronic myeloid leukemia.
Last patient, I think.
Yeah.
Some questions on how do we manage hepatitis B? Does he go for a renal transplant? So, what will be your advice to this patient prior to doing renal transplant? Do you preempt starting antivirals in this patient?
Verghese, you can start opening the.
It's a tenofovir. We have to give patient planning for renal transplant. Even now, actually, patient is in inactive carrier stage. So if they're planning for renal transplant, he will be needing immunosuppressant. So we have to start him on tenofovir, sir. Tenofovir, alafenamide, or
Tenofovir or TAF?
Professor Venkat, are you showing the case from your side?
LVK?
Because it's already 9:20, we can ask LVK to show his case.
LVK, please show your slide.
Until in the meanwhile, I will do a formal introduction of Dr. Cyriac Abby Phillips. Now that everyone is logged in, Cyriac Abby Phillips did his MBBS from Bangalore St. John's, then later MD from Sarkar Medical College, Calcutta, and had his DM from ILBS under great Professor Shivasari.
DM in hepatology, that's very important.
DM in hepatology, yeah. He is one among the few full-time hepatologists in Kerala. And I would like to project Dr. Abi as the model student, because you won't find this many publications for a young person like him. I was trying to count the number of publications before this presentation, but I was not able to do that. I am not telling the count. Okay, I am actually really envious of you. Of having so many publications, and of late Cyriac Abhi is busy fighting attacks from all the Irish people because of his article on herbal medicines and liver toxicity.
And FMT.
Yeah, and of course there are a lot of areas where he is interested, FMT, liver disease, in every aspect. And interestingly, I have also noticed that you have a publication on polycystic disease. Okay.
Abby, I'm not envious of you. I'm proud of you. Okay.
Thank you, sir, for the introduction.
I'm proud of you.
And I think every DNB student should make him a model. And he can not during the namesake research during your training, but continued interest in research even after completion of your training, and take it as a passion. And we are all proud of you, Abhi.
Thank you, sir.
LVK, ask LVK to open up, no?
Professor LVK, are you there?
I think he's there.
I'm there, but I've sent that to you.
Have you found out your slides? If there are any delays, I think we will quickly go through the last case as a short case.
In our case, we postpone.
I think we just do it, sir. Next time we'll bring in that case. I didn't really.
I think we'll continue the VT because that case is a little long, no?
Which one?
That short case. Don't do it.
Okay, so we will
show you the next time.
Maybe you can just.
Nothing again. Probably managing of this gastric virus only.
You can say something.
Sometime later I can do it. Because
it's not opening.
Some problem.
Venkat's file is not opening. So we have around 9 minutes. Should we take that short case or not?
Not required.
Not
Maybe we can tell something about, say, that alcoholic hepatitis. No, you have a lot of papers on FMT. You can just tell us something about that.
Yes, ma'am. And I think a lot of questions that they might ask. I mean, normally that they ask is actually treatment.
That's what we want. Yeah.
Treatment of alcoholic hepatitis.
Yeah.
So, I mean, nobody actually should mention any of the experimental therapies. We should go by the book. So your first option is to look at the DF or the MELD score. If it is more than 32 or if MELD is more than 22, then you start the patient on corticosteroids. So whether to add an antibiotic or not, there is a recent study that is now it was just recently shown in the current ongoing International Liver Congress in EASL, where they showed that addition of an antibiotic along with steroids in acute and chronic liver failure due to alcoholic hepatitis actually did not improve clinical outcomes, but it did reduce infection episodes, but it did not improve the mortality. So whether to add an antibiotic along with the steroid, that question is probably answered with this large randomized trial. So that is the latest in alcoholic hepatitis steroid treatment. Now next is the other option. Yes, sir.
And
yes, sir. That study.
That is a
study. They used amoxicillin, clavulanic acid. Amoxicillin, and this actually shows one more thing. Amoxicillin and clavulanic acid is not very toxic in the short term in advanced liver disease. So we can actually safely use it because none of the patients developed any DILI, add-on DILI because of this combination. And second is that one should not actually look at pentoxifillin or other solitary therapeutic options like N-acetylcysteine or even I've seen people prescribing Silimarin. That should not be there, or UDCA. Even that is not recommended. Now, the best combination, some examiners might ask you, this is based on a network analysis of all the trials published in gastroenterology by Abhishek Singh. That is the best combination is actually corticosteroid with N-acetylcysteine. And this is the best combination for short-term management or improvement in mortality in alcoholic hepatitis. Now, if a patient is not a candidate for alcoholic hepatitis, what would you do? That is the biggest question. So if he has active sepsis or a sepsis that is recently getting controlled or a GI bleed, then you don't give steroids. It's going to be a problem. So in such patients, we advise liver transplantation. And whom to select? We have to follow the institutional policy. Every institution has separate policies. And one of the best policies that we discussed recently was the French-Belgium criteria, where they actually assess the chances of relapse or alcohol use disorder post-transplant. And this is also an important aspect while choosing patients for alcoholic hepatitis patients for liver transplantation. Now, what if the patient is actually a heavy drinker and Cage questionnaire is still quite high and you cannot actually offer a transplant and there is high risk of relapse? So in such patients, you always tell the examiner that you would probably advise the patient to go into a clinical trial. And that is where your FMT, your growth factors and all that come in. So there is a recent study that was from ILBS where they showed that growth factor therapy, DCS, actually improves alcohol survival in alcoholic hepatitis. But the problem is that this is never replicated. So there is no replication study. It's just a single study. And FMT, definitely, there is a lot more that we need to know about it. And it is not recommended as a treatment. But inside clinical protocols, yes, one can actually try FMT to see for salvage options, but not for a treatment option.
Abhi, through other things is, it is always important that we have a infection screening before you start steroids, but there are two differences. If you have an infection before starting steroids, you can give antibiotics, eradicate, and still start steroids. The mortality has not become higher just because you had a pre-corticosteroid infection, which can be treated and still, then later you can still steroids, and the response is almost the same. But it's entirely different when I think in EASL you would have seen another paper, there's a difference between infection before starting steroids
and
after steroids. After steroids, you have more of fungal infections and the mortality is quite high. So they have shown one paper where there is the infection before steroids is much different from the infections while you are on steroids. But if you have infections before steroids, you could still eradicate and still start steroids. It doesn't make the mortality is not different just because there was an infection. And the other thing is there were some papers about plasma volume exchange on acute alcoholic hepatitis, but I think the major work came from John Hopkins group, where they said in alcoholic hepatitis it does not work much, and it's much better sense to put them onto a transplant in these patients.
And even the ELAD trial failed in alcoholic hepatitis.
Yeah. And you told about that French-Belgium criteria. I was in Paul Bruce in 2009 when we did the first 26 transplants in alcoholic hepatitis. As you said, the selection criteria is very, very stiff. Actually, very, very select population was taken and your thing. But surprisingly, in that 26 patients, only 2 relapsed after 764 days. In that 26 patients who underwent transplant. So 2 relapsed after this. Any other take on the enteral nutrition plus steroids?
So I mean, these are actually not clinically proven, sir. I mean, even though we say that there is definitely a role for enteral nutrition. I mean, this is 1948 Mendenhall paper where he said that just giving enteral nutrition, you can actually improve the survival by 30% just by nutrition. So definitely enteral nutrition has a role to play. But we actually don't have any comparative studies with and without steroids in this aspect. If I am, I'm not sure if there is something new has come up. But what I know is there are no head-to-head comparisons on that.
The newest has come is that giving antibiotics with steroids. I think that's what came up in EASL these days.
And there is a doubt that everybody asks: how do you taper steroids? So if you look at the actual protocol for steroid treatment in alcoholic hepatitis, there is no tapering. So you give 40 milligrams up to 28 days and then stop it. There is no tapering.
This tapering was brought in by the John Hopkins. If you look at, because they did now John Hopkins has probably done the maximum liver of transplants in the acute alcoholic hepatitis. So they only brought in the 20 milligrams the next 2 weeks and then you stop it. But actually, when your recommendation was there, it was 28 days and then you stop it.
Yeah, then stop it. Same with pentoxifillin also, but nobody uses pentoxifillin these days.
No, the STOP-ACT trial has shown that pentoxin is not useful.
You stop it abruptly, is it, after 28 days, or you taper it after 28?
Stop it. No, you don't taper.
Stop it abruptly.
Stop it.
After 28.
There's a question, what is the dose of NAC in alcoholic hepatitis?
So if you look at the NAC protocols, they're very heterogeneous. So some have actually used the paracetamol poisoning protocol for NAC. And some have used somewhere around 5 to 10 milligram per kilogram per day for 5 to 7 days. So I would suggest reading the paper by Singh et al. Gastroenterology. I think it's 2018, where he has actually mentioned different methods of giving NAC and the best one. So that paper is actually a must read for everyone because it shows all the network analysis of best treatments for alcoholic hepatitis.
There is one more question about how the selection criteria for liver transplantation in alcoholic hepatitis. Early liver transplant. How do you select patients?
So there is one very latest paper by Juan Pablo Arab, and that is published in Journal of Hepatology, where he has actually mentioned that the group that actually improves or benefits from steroid are the ones who have, even though I'm not very sure of how it comes to be, are the ones with MELD of 29 to 40. So 29 to 40 MELD, if you give steroids, they have some survival benefit at 28 days. So if a patient is on steroid and there is worsening or new onset organ failures, that is the time when you actually decide on early transplant. So if a patient who is not eligible for steroids and a patient who is actually worsening on steroids, you can look at the Lille score. And those patients are the ones who actually need to be transferred to an early transplant. So in this scenario, looking at the stringent criteria that are in the published literature, we might not actually include that patient, our patient especially. The Indian patients don't come into that. But then if there is good family support, social support, and psychosocial support, definitely liver transplant is the option for these patients. So that is when we consider as early liver transplant.
Okay. Thank you. Dr. Sojan, are you there?
Thank you, Abby, for that wonderful session. Dr. LBK, for both your inputs, both hepatologists, leading hepatologists, helped me to go through this session. Thank you so much.
Okay, thank you, Jayanthi ma'am, and Dr. Cyriac, Dr.
Thank you, sir.
PK, and all the students who have participated, and wish you a good reading. I think there is a lot of need for reading because you have to be supported with a lot of theoretical knowledge in the background, because otherwise it will be difficult to discuss cases. Okay, so please read. That is my simple suggestion. With these words, we will wind up today's session, and thank you all. Good night.
Good night.
Good night.
Thank you, Abby. Thank you, LBK. Thank you. All the best. Best wishes to you, Abby.
Thank you.